In today's times, doctors and patients have the good fortune of having several choices for treating a patient with chronic lymphocytic leukemia or CLL. And my emphasis is that we should try to determine for each person, each patient, as to what are the various items that we should choose or determine. For example, is the patient previously treated, or the patient is what we call treatment naive? Because the choices for the treatment naive are larger and more varied than in the previously treated people. CLL is a disease of the elderly people, but within that elderly group, there are some people who are less elderly and others who are more elderly. Because some people who are 65 and act like 85, and other people who are 65, they may act like 60 or 50, and therefore the treatment should be individualized. And in other words, elderly people come with comorbidities and therefore accordingly influencing what we call performance status, whether we use Karnofsky score or we use ECOG score. And finally, two molecular markers. Is the patient carrying a bad prognosis marker with the chromosome 17p deletion? Because those people do not respond to all the standard treatments, and even if they do respond, the duration of responses are very short. So 17p deletion patients are not the right candidates for chemoimmunotherapy. And those are the patients who are better treated with ibrutinib or BTK inhibitor or venetoclax or BCL2 inhibitor or allogeneic stem cell transplant. And finally, if the patient has mutated IGVH gene, those are the patients who do well, have longer life expectancy as compared to the unmutated group. So I try to determine, and I recommend all physicians who take care of CLL patients to check off those elements. In the relatively younger CLL person with the mutated IGVH gene without 17p deletion, FCR, the chemoimmunotherapy, offers the best choice. Otherwise, across the board, ibrutinib or obinutuzumab plus chlorambucil are effective alternatives.